There's a lot of talk in the news and spanning many of the social media networks with titles like "Prostate Cancer Screening Recommendations Get Rolled Back by the US Task Force." So what's a man to do? Are we now all supposed to be getting prostate screening tests? And what does that actually mean? Let's start with screening. This should consist of taking a patient's history. Why is that important? Certain factors will increase your risk of developing prostate cancer and should be taken into account. This is followed by a digital rectal examination. For those of you of the right age range, for this advice that applies to you, that's men between 55 and 69, you may remember that iconic scene from Fletch from 1985 starring Chevy Chase, where he receives this very examination. Moon River? Not to make light of the examination, but much like colonoscopy, it's an essential part of our diagnostic suite. Simple and painless. This is followed by a blood test to measure the prostate-specific antigen, or PSA. Elevated levels of this in the blood can sometimes indicate prostate problems, but part of the reason for the confusion and changing guidelines is the lack of specificity of this test. In medicine, we talk about specificity and sensitivity of test that's defined by the rate of false positives and false negatives and the ratios. The short version is there's no clear cutoff point as to what's normal versus abnormal. We also see significant percentages of men who've had normal PSA tests, but in study follow-up were found to have prostate cancers. This paper from 2012 reviews the clinical utility of the PSA prostate cancer antigen and highlights the further complicating issue that men have also found to have elevated PSA levels but no prostate cancer. And the link between identification of prostate cancer and the treatment and ultimately positive outcome effectiveness still remains blurred. There's further evidence for this confusion in this 2015 meta-analysis that demonstrated a high incidence of latent or asymptomatic prostate cancer found after death and increases with patients in increasing age. Somewhere between 20 to 30% of this age group of 55 to 59-year-olds have prostate cancer that was asymptomatic. The proponents of prostate cancer screening need to be wary of the high risk of overdiagnosis, as the study authors put it. So what's the change in guidance? Well, the United States Preventative Service Task Force changed its recommendation on prostate cancer screening from a D, which means don't do it, to a C, which means you should discuss it with your doctor. I'd hardly describe this as prostate screening recommendations getting rolled back, but rather the thoughtful analysis of the new data. In this case, a study published in 2012 showing a reduced relative risk from offering screening by 30%, and a large randomized controlled study that published in 2014 that updated an earlier study that showed offering men screening reduced their relative risk of dying of prostate cancer over 13 years by 21%. But it's important to understand the difference between relative and absolute risk. We as humans are very poor at assessing risk in general, and relative and absolute risk just makes this harder. As Aaron Carroll, the incidental economist, highlighted in his analysis of the topic, he gave a clear explanation of absolute versus relative risk tied to this data. According to these studies, a 55-year-old man has a 0.6% chance of dying of prostate cancer over 10 to 15 years. If he's screened, that chance goes down to 0.5%. That's how you get almost a 20% relative risk reduction, but an absolute reduction of only 0.1 percentage points. So out of 1,000 men screened, 80 will eventually have surgery or radiation. 3 will avoid the spread of cancer to other organs, 1 or 2 will avoid death from prostate cancer, and 60 will have urinary incontinence and/or impotence. Many men will probably still think the risks outweigh the benefits. The other important point here is that this change only applies to men aged 55 to 69. For those of you over the age of 70, the advice remains a solid D. Avoid this screening. So what should you do? Take advice from the task force and talk to your physician. Discuss your personal circumstances and your risk profile and understand the potential consequences of testing your PSA, and if it proves positive, what's the path for you that you're going to have to walk as a result of this high level or elevated level of PSA. So the incremental steps to men's prostate health: assess your own personal risk of prostate cancer, educate yourself on prostate cancer testing and treatments, understand absolute versus relative risk. If you fall in the 55 to 69 age group, see your physician. Discuss your own personal risk profile. And if you're over 70, stay educated, but don't get tested. I'm Dr. Nick, and I'm the Incrementalist.